how to go about the order set. Was that clear enough? Great. So now we'll go about COVID specifics, and I will tell you a couple of stuff, which hopefully will be helpful. So you will try to see, so you need to know, like, there is like kind of very repeated scenario you will see in the COVID patients. Most of the patients, they got infected, they start the symptoms, 7 days after that, they get admitted. So you either see the patients from the ED, so you see them like 1 week after their initial symptoms, or they were admitted and then you see them when the hospitalist or the medicine team call you like, hey, the oxygen requirements are now like high flow, 80%, and the patient is still full code, he might be heading towards intubation. So the subjective part is talking to the patient, and like he will tell you about what his symptoms, which is basically like a kind of like a viral prodrome. Like he will tell you like, yeah, 7 days ago, we have like a couple of COVID people already at home. Symptoms, basically fever, cough, sore throat, whatever they will tell you. And it's getting worse over the last 2 days. I came into the hospital. Then you need to figure out, like, probably sometimes the patient is too altered to tell you. You need to ask the family what happened and how the problem progressed, and who else is sick at home, who actually tested positive. Some people tested positive before the hospital. You need to know when was the patient first tested positive for COVID. You need to just dig for a little bit more about like the comorbidities, if the patient have like a respiratory disease or he's on home oxygen, stuff like that. If the patient an upgrade, you need to briefly describe the hospital course. Like, let's say the patient admitted 2 days ago, he was started on remdesivir and dexamethasone, and he was initially on 6 liters. Now he is on like 70% high flow. So that's how you tell it to your attending. That's the, like, he came in initially with the viral prodrome. He came in here admitted, started on COVID treatments, and his oxygen requirement went up. And this is why he's upgraded to the ICU. This is usually the reason. You need to figure out the volume status, which is what we already discussed earlier, from examination, from labs. You might need to order BNP, N as in Nancy, because whenever I say it, people think it's a BMP, metabolic panel, but it's BMP. And then always need to mention in your notes, like remdesivir, which day is the patient on, dexamethasone, which day is he on. Like remdesivir, 5 days. If the patient is not taking remdesivir, it was declined for what reason? Is it like elevated LFTs, or is it ESRD, stuff like that? So you need to mention why the patient is not taking remdesivir if he's not. Then if you are covering bacterial component, you need to justify that. Is it like an atypical X-ray? Is it elevated procalcitonin, which suggests a bacterial infection? Or like the patient is lacking improvement with the standard COVID treatment, and we think there might be a bacterial pneumonia on top of it. So that's why we're covering him for CAP. DVT prophylaxis, we went through that and we discussed it. And then the big one, the code status. That's what Samir will tell you about a little bit. So there is a big problem right now because we're kind of seeing a trend where, so just to give you an idea about like what from our experience so far with the COVID people, once we intubate, it's kind of like take an extended, some people take like forever to get extubated, and some people even fail to extubate. Like we don't have an end for that until the patient switch to comfort care. So these are kind of like challenging now. They are not offering intubation for everyone. If the patient is very poor functional status at the baseline, like he's like CVA with like bed bound and have like multiple comorbidities, we might not even offer intubation in the first place because he might take a spot in the ICU and there is no hope that he will be extubated, and we're just wasting like a life-saving measure for like someone who might make it through an intubation. So it's kind of like a difficult situation right now. It's emotionally draining, but this is very important. You guys will be on the face of it, because whenever you receive a call from a hospitalist, they usually don't go deep with these discussions with the patient when they admit. And when they try to upgrade, they don't even go and discuss with the patient. You probably, when you do the assessment initially, you will discuss with the patient like, hey, you're not doing well, you're heading into an intubation. Is that an option you're thinking about or not? And now Samir will tell you about like a new thing. About the.
Yeah, so there's a lot to this, and I think all the interns I've asked them, like just to recap what was the hardest part of ICU, especially right now. It's not the presser ladder, it's not the vent settings, it's the family conversations and the goals of care discussions. So I think we should take some time out to just kind of walk through how this conversation should go. It's something that I'm sure all of you have done. I'm sure Charlie does it in the ED. I'm sure, like Luis, you do it every time you admit somebody, and same with everyone else. So just general tips on it. I think the conversation should begin with just like, you want to make sure that you're just normalizing it like you always do. Tell them that this is something that I discuss with all of my patients when they're admitted to the hospital, and it's especially important in the setting of COVID. So I want to talk with you about something called code status, and then you can ask them, are you familiar with code status? Are you familiar with CPR? See where their level of understanding is, and then talk to them that different people have different goals in their care. Some people, and this is something I like to do, I like to say some people think about quantity in their life, and some people think about quality of life. So using terms like these are better than what many times you guys will hear of, do you want us to do everything? I think we need to abandon that phrase of saying, do you want us to do everything? Because it's very easy to say, yes, I want to do everything. So when you bring up code status, it's important to realize that it's not like a menu of things. In the event of cardiopulmonary arrest, it's all one resuscitative effort, and that would include chest compressions, and that would include being attached to a mechanical ventilator to support your breathing. So when we have these discussions with patients who have COVID, it's not all about just resuscitation, it's also about intubation. So it's good to separate the two ideas and goals of care discussion. One being, what do we do if you die, basically? What do we do in cardiopulmonary arrest? Do you want us to do the chest compressions, the CPR, the resuscitative efforts of hooking up to mechanical ventilator? Or if that is not something that you wish to be done to you, we also still can talk about putting you on a mechanical ventilator just in the context of your breathing getting worse with COVID-19. So because it's hard as an intern to talk about something that you haven't seen as often as maybe some other folks, I just want to kind of give you all an idea of what we're seeing on ICU. We're observing that, and this is based off of some of the Chinese data too, that many of these patients, they were vented for about 21 days in their COVID course. But what we're using is trajectory. And this is not something I'm saying that you talk about to the patient, but it's just something to think about. We have seen patients that in the first week, they'll peak, they'll require a maximum oxygen level of even up to 100%. They were paralyzed prone, but then we're starting to see at the end of that week, they're needing less and less to support their lungs. So we're seeing like a good trajectory. Like it's all about seeing where is the trajectory going. We see some patients where we're at 2 weeks and we're still every night struggling to prone them, paralyze them, grasping at straws. So it's good to know this, because when you talk to a patient, you can talk about something that's called a time-limited trial, where we can give you a shot on the ventilator, we can see where you're going, but I think if you're someone who doesn't want to be put on a machine to the point that we think that it's not going to help you, then let us know that. Talk to your family about this, because we're usually seeing these patients when they're just on 50% high flow or something, so they have the chance to talk to their family. So it's a good time that you plant the seed in their head when you see them for the initial consult, and ask them to talk to their family about it. I've had patients who tell me that I think if I don't look like I'm improving after a week, I don't think I would want to go through being on the ventilator if the team thinks that I'm not going to make it. But if you think I have a shot and you want to do this, then go ahead. I've seen 1 week trials, 2 week trials. I've seen patients who say, I just want to try the high flow and the BiPAP. I never want to be on a tube. And we respect that. If their oxygen goes to the 80s and they're still functional, hey, still get the remdesivir or dexamethasone. But if they start getting uncomfortable, then we can talk to them about comfort care. And that's something the hospitalists should be able to do on their own. We don't need to admit DNI patients with that plan of action where if they can't make it, then comfort care. So it's a lot. I mean, these are heavy discussions and they're important. So I think it's a day-by-day thing. If you're calling the family every day to update them, you'll get a chance to slowly talk about these things. And if you get the benefit of talking to the patient themselves and getting the wishes of the patient and documenting that, saying that they wanted to just try out the ventilator, then you remove that guilt from the family. There wouldn't be a reason to ask them, do you want us to stop our mechanical ventilation, because you've already had this talk with their loved one. You absolve them of any guilt. So I think these are some things to consider. Just, I guess, key points from that is have the conversation about cardiopulmonary arrest as one conversation, have the conversation about mechanical ventilation as a separate conversation, and then don't be afraid to plant the seed and follow up, and always ask them who would be their surrogate decision maker. And you can even let them know, I'm asking you this because it's not that I think we need to intubate you right now. I'm not even sure if you would need to be on it, but I'm asking you because if we do run into the situation where you're intubated, you will be sedated and not able to answer these questions. So pick someone in your life that you trust to make these decisions for you and talk to them tonight. So that's my 2 cents on addressing this whole code status thing. It's becoming a lot like a palliative care rotation, sadly, on ICU.
Yeah, so
yeah. I guess one more thing. Do you all know like what comfort care is? Like when I say comfort measures only versus DNR, DNI, I just want to make sure that everyone is on the same page.
Yeah, exactly. That's very important. Do you guys know what comfort is? Do you know what the DNR, DNI, like all the, like, do you know what the difference? Like, do you know there's an order set for comfort care?
Okay, in case somebody isn't as familiar with it, I just want to say, so DNR, DNI, it's literally just what do we do in the situation of cardiopulmonary arrest? That's it. So your DNR, DNI, you're still getting, you're still getting treated for everything. Comfort care is that the only measures that they're taking are to make them comfortable. So that would be pain medication, benzos, it's really very much geared towards end of life. So I just want to make that distinction clear that DNR, DNI, we're still treating them. It's just what do we do if their heart stops? And then comfort measures is we don't think that you're necessarily going to improve with all of these things. These things might not be within your goal to be uncomfortable, hooked up to lines, machines. So we're going to just target comfort. So we're not giving them pressors. We're not giving them ventilation. We're not doing these things. Typically we see it in the ICU context as it's the end of the line, and we actually allow 1 to 2 family members to come in when you transition to someone to comfort care as of last week at least, so that they could watch their loved one passed away.
Okay, probably you guys, I'm not sure, I was assuming, but I think you guys need to know like the oxygen ladder. This is the thing that you will be dealing with every single day. So you need to know which one is higher, which one is lower on the scale when we discuss oxygen requirements for patients. And if the patient is getting more hypoxic, what is the next level? What, like, you hear things from the nurses, from the RTs. You need to know sometimes, like, is this good? Is this bad? I don't know. Like, you need to figure out like some certain terminology. So basically, in terms of oxygen, most people like nasal cannula, like maximum they can get 6 liters. If they fail, they can go to oxygen mask or non-rebreather up to 15 liters, which is technically 100%, but there's some leaks, so it's not fully 100% FiO2.